Hi, my name is Brian Peng and I've been working with Myopia Profile for over 2 years now, alongside being a clinical optometrist in practice just outside of Sydney, Australia. I qualified with a Bachelor in Vision Science and Masters in Optometry from the University of New South Wales in 2020. In my work with Myopia Profile, I've written numerous educational articles for practitioners on myopiaprofile.com and for parents on mykidsvision.org, and also develop online courses. This topic today is one that I've spent some significant time on understanding to write articles and an upcoming online course called Ocular Pathology in Myopia. When it comes to myopia management, the functional benefits are well known. Myopia correction provides clear and comfortable vision, and myopia control results in the child having less blurred vision between eye exams, less frequent prescription changes during school years, and hopefully by adulthood, myopia progression will be slowed as much as possible to preserve unaided distance vision and maintain good best corrected visual acuities. These benefits are clear and well aligned between the eye care practitioner, the parents, and most importantly, the child. The focus of this lesson, however, is to remind us the value of myopia management in terms of minimizing its potential costs to a patient's long-term eye health. The long-term goal of myopia management is to minimize the lifetime risk of visual impairment from myopia-associated eye diseases. Excessive axial length growth in childhood is accompanied by an increase in diopters of myopia and increased risk of pathology such as myopic macular degeneration, retinal detachment, and cataracts. Pathologic myopia describes the structural changes in the posterior segment and their visual consequences. This is frequently seen in those with high myopia, but complications can still occur at any level of myopia. High levels of myopia are associated with an escalating risk of pathology in the posterior segment of the eye, such as posterior staphyloma, myopic maculopathy, and glaucoma. Abnormalities within the vitreous, retina, RPE, Bruch's membrane, choroid, optic nerve, and sclera can develop secondary to excessive axial elongation. The impact of structural changes ranges from mechanical strain, vascular changes, stretching and thinning of tissues, as well as atrophy in more advanced stages. Advances in knowledge of disease progression and better imaging technologies have improved our diagnostic power and ability to monitor disease. Myopic maculopathy is one of the most prevalent disease complications observed in high myopia, affecting about 1.2% of the population. Myopic maculopathy refers to a range of macular structural changes induced by excessive axial length and/or posterior staphyloma. Stress at the posterior pole leads to focal or diffuse degeneration of the retina, sclera, or choroid, which can then induce pathological changes in other tissues, eventuating in central vision loss. Posterior staphyloma results from the focal kind, causing a peripapillary or macular outpouching that is a hallmark of myopic maculopathy. Ruiz-Medrano et al. Have suggested categorizing the spectrum of myopic maculopathy into atrophic, tractional, and neovascular components. The ATN classification system, as it's called, assists clinicians in grading myopic maculopathy as different types of maculopathy may coexist in the same eye. Atrophic myopic maculopathy is characterized by slowly progressive RPE and chorioretinal atrophy, which often begin as a tessellated fundus. This then progresses to diffuse atrophy, followed by growth of the atrophic areas into atrophic patches, which eventually coalesce into geographic atrophy. In many ways, it is the myopic equivalent of age-related macular degeneration. Therefore, a relatively innocuous tessellated fundus is an early marker of myopic retinopathy. Sadly, geographic atrophy is untreatable. Management revolves around optical interventions and low vision aids. Myopic traction maculopathy encompasses a spectrum of myopia-related vitreomacular interface disorders such as vitreomacular traction, foveoschisis, and macular hole. Vitreomacular pathologies are more prevalent in highly myopic eyes. As the eye elongates, the vitreoretinal complex fails to hold together against the competing force of the sclera expanding. This leads to splitting of the tissue both between and within different layers of the retina. Most eyes with stable disease are simply observed, but progressive cases may require vitrectomy to relieve traction at the macula. Myopic CNV occurs secondary to ruptures in Bruch's membrane, for example lacquer cracks. This may cause an increase in vascular endothelial growth factor diffusing through the break, promoting the infiltration of new vessels. A Fuchs spot refers to a dark spot in the macula that arises from RPE hyperplasia and migration to the retina following an episode of CNV. Over time, chorioretinal atrophy will typically develop around the lesion. Just like wet macular degeneration, intravitreal injections are the preferred first-line therapy, which have shown to be safe and effective for myopic CNV. Rheumatogenic retinal detachment is a well-known sight-threatening complication of myopia. It arises when fluid from the vitreous cavity enters a full-thickness retinal break, inducing a separation of the neurosensory retina from the underlying RPE. The risk of developing a retinal break is increased in myopic eyes and eyes with longer axial length, which are more likely to have pre-existing retinal thinning, peripheral retinal lesions, and premature PVD. Compared with non-myopic eyes, lower levels of myopia, such as less than 3 diopters, attract a 4-fold increase of retinal detachment, while higher levels of myopia have an 8 to 10-fold increased risk of detachment. Cataracts are a leading cause of visual impairment in the world. Myopia may be associated with nuclear and posterior subcapsular cataract, particularly at higher degrees of myopia. On the other hand, population-based studies do not support any association of myopia with cortical cataract. Because myopic shifts normally accompany nuclear cataract, it is unclear whether myopia predisposes an individual to cataract development or the reverse. Research suggests an interesting mechanism that the increased liquefaction of the vitreous in myopic eyes speeds up oxidation of the lens, causing nuclear cataract. Posterior subcapsular cataract development is also thought to be related to oxidative stress and inflammation of the lens, with more multifactorial contributions. A consistent finding amongst research is that myopia is associated with an increased risk of developing open-angle glaucoma at a dose-dependent response. The risk of glaucoma is approximately double at higher degrees of myopia. But despite the strong evidence, the pathogenesis is poorly understood. The mechanical hypothesis suggests that the disconfiguration of myopic eyes results in optic nerve head tissue that is more susceptible to damage by elevated or apparently normalized IOPs. Myopic eyes have numerous anatomical alterations as a consequence of axial elongation, such as tilted discs and shifted retinal nerve fiber layer bundles. Myopia and myopic disc configuration can also confound interpretation of the optic nerve and visual field result, mimicking glaucoma. It's particularly difficult to distinguish moderate to high myopia from glaucoma based on data at any given point in time. So the best way of distinguishing myopic optic neuropathy from progressive and treatable glaucoma is to check progression over time in terms of optic disc appearance, RNFL analysis, and the visual field results. Compare disc photos over time. Assessing disc photos over time can assist in identifying enlarged cupping, new notching or new RNFL defects, bayoneting of the vessels, increasing peripapillary atrophy, and other features characteristic of glaucoma. Check for asymmetry on the OCT RNFL deviation map to identify localized defects. RNFL distribution bundles are often shifted in myopic eyes, causing OCT algorithms to flag false positive, red disease, or even false negative, green disease, nerve fiber layer thinning. Visual field follow-up is needed to confirm progression in myopic eyes. As with any progressive condition, it is often not possible to distinguish glaucomatous from non-glaucomatous disease just from a single examination. The International Myopia Institute Clinical Management Guidelines provide a robust framework for assessing myopes in practice. As myopia is frequently linked with posterior segment complications, it is important to thoroughly examine the fundus for any abnormalities. Axial length data provides a key diagnostic indicator for lifelong risk of ocular disease linked to higher levels of myopia. As mentioned earlier, an axial length greater than 26 millimeters bears a high risk of myopia-related pathology. Managing patients at risk of pathologic myopia requires a careful approach where the eye care practitioner must balance optical needs with ocular health needs. Initiate early evidence-based myopia control to limit the severity of myopia and risk of eye disease. Follow up with patients at least every 6 months during myopia management and at least annually for adult myopes. Annual fundus exam, preferably with dilation and imaging, ensures the myope is appropriately screened for any evidence of pathology. Next, educate patients on the risk of eye disease with progressive myopia and that the risk is proportional to the severity of myopia. Patients should be counseled on the symptoms of retinal break in order to recognize and appropriately respond to an ocular emergency. Finally, patients with suspected or established pathology should be placed under collaborative care with ophthalmology to receive the best quality of care. Thanks for tuning into this presentation, and I wish you all the best in practice.